We continue our study of infections of the lungs, and we move to pneumonia, which is inflammation of the lungs, and this can be caused from a number of different sources. Certainly infections, what we're dealing with now, inhalation of noxious gas or gas that causes damage to the lungs. Noxious can refer to, in this particular case, gases that make us sick, but it can also be, the word noxious can mean pain-producing. And then certainly getting your lungs at the level of your lungs, of the alveoli and the last bronchial chain, are sterile. But if you put soup or cracker or Diet Coke or Gatorade in your lungs, that causes an irritation, and we're vulnerable to infection. And this is really what happens at this microscopic level of the acini or the alveoli, fighting this bacterial infection. This gets filled up with fluid. Well, no gas exchange is happening here. So that portion of the lung is gone. You fill up a lung with this infection. It's very problematic for health. People who are confined to bed are very vulnerable to pneumonia because you're taking shallow breaths typically, and this is one reason why everyone who's in hospital who possibly needs to get up and move, and also to do preventive breathing, deep breathing. This is a spirometer, that incentive spirometer, where there's a little ball and you want to keep the ball elevated by breathing in deeply and exhaling deeply. And then I talked to you about one of the causes of pneumonia is aspiration. Who's vulnerable to aspiration? Well, people whose gag reflex is depressed. In the little people, the little person, and older people. So contrast these. And in those who are whose autonomic nervous systems are affected by drugs, alcohol, sedation, or loss of cognitive or central nervous system control, and so they're vulnerable to aspirating. Here's consolidation. The healthy lung tissue shows as dark. Okay, where there's density, there's inflammation and purulent material build up in the lung. That means that lung is not functional. And then there are some other x-rays available to you that demonstrates consolidation in the lungs. Okay, and we move now to obstructive lung disease, where the impediments to ventilation are occurring, and I want you to be way heads up about the troika of conditions that lead to chronic obstructive pulmonary disease, and those include chronic bronchitis, emphysema, and asthma. And in bronchitis, there's a thickening of the smooth lining, the smooth muscles in the bronchioles, and also secretion of fluid. In emphysema, this is normal lung tissue. There's a loss of elastic quality, or the walls of the alveoli are broken down, and so you see in this diseased or emphysemic alveolar bed that the partitions are gone and there's just a bunch of dead space, and they have a very hard time expelling deoxygenated blood. and this is very problematic. So it's a combination of bronchitis. When I say it, COPD, bronchitis, asthma, and emphysema. In asthma, there are tremendous secretions and thickening of, or I'll just say the lumen. I should be over here. The lumen closes down, so there's less gas exchange. So right now, we're studying the obstructive types of lung pathology. Management of COPD certainly is exogenous or supplemental oxygen, because they can't extract enough oxygen from ambient air. They need to have very often pulsed or ad libitum oxygen of different percentage, higher, richer mixture, sometimes 100% oxygen, and then metered administration of bronchodilators that, as we indicated in bronchitis and asthma, there's a diminishing of the lumen of the tubing of the bronchioles and the the bronchi and the bronchioles. Asthma is reversible, but it's chronic in nature, and there can be different causative factors of this, and they're listed for you here. This is an artist's depiction of the muscles around the bronchi are contracting. In asthma, there's a filling up of the lumen with secretions, and there's just a reduced capacity to exchange air. And this comes from different localities. Could be psychological, could be endocrinological, could be infection, it could be a result of autoimmunity or inhalation of a noxious gas. Extrinsic mediators of asthma, I've tried to depict where these different threats to or triggers for asthma are in our environment. So certainly smoking is a massive threat. This has been, you accept that. It's a massive threat to the health of the long-term health, and in the short run, people who have a tendency toward lung disease, there's no way they should be sucking on a tailpipe. Where's that little guy with the tailpipe? Don't suck on the tailpipe. Probably don't want to suck on a cigarette. And then exercise-induced asthma. The mediators of asthma can be exacerbated by this. And then vermin carry things that can trigger asthma, and the cold can trigger asthma as well. And so prophylactic care of exercise-induced asthma, typically pre-game albuterol, and then there might be another inhalant drug for during the game if there is the manifestation of asthma. But the best asthma is episode is the one that doesn't happen, and so prophylactic use of albuterol is a good thing. And the warm-up shouldn't be super gradual. Getting right into activity, be up-tempo. The metered dose inhaler is important, because if you just took this atomizer and shook it up and then sprayed it directly into the mouth, a high percentage gets stuck to the tongue and doesn't get to the lungs. And so mixing this here, shake it, spray it, fills that chamber, and then inhale that gas is a way greater delivery in order to affect bronchodilation. Okay. when a person has shortness of breath because of obstruction, remember we started with infection in the previous video and we moved to obstructive lung diseases, they can experience shortness of breath. Now, there's two ways to think of this illustration. One is when you see somebody in these postures, they maximize their muscles of respiration in these postures. Okay, their gravity, by leaning forward, there's less influence of gravity. It takes less work to inhale and exhale. You could diagnose that a person's having trouble breathing, or if a person's having trouble breathing, you advocate for them getting into these positions. The best positions for enhancing breathing are Fowler's. This is Fowler's. It's a semi-reclining position. And the definition of orthopnic breathing is breathing is not going well in a supine position or a when they're laying down, and so getting them up and leaning forward can enhance them, and that's called the orthopnic position. There's other information available to you to how to enhance breathing dynamics. Certainly we talked about vasodilators, and then accentuating exhalation as opposed to inhalation. Exhaling through pursed lips equalizes pressure and allows for a person, particularly with emphysema, to exhale more of that air that's in dead space. So it's inhalation, exhalation, longer period of time with increased pressure through pursed lips, and then exercising appropriate to what's going on. I alluded previously to a chronic condition that is a sequel to chronic lung infections. It's called bronchiectasis, and it results from so much inflammation over such a long period of time that scar tissue develops and they're not able to extract air from as in normal lung tissue. Quality of life really goes down when this happens because you have less lung available to you. If you have bronchiectasia for a long period of time or other obstructive pathology, it can lead to the right side of the heart becoming dilated, and this person has what is known as cor pulmonale, and this moon face is indicative of congestive heart failure traced to the right side of the heart. Okay, and then collapsed lung. In a way, this is obstructive. If a lung collapses down on itself, there's no gas exchange. It could be spontaneous. I'll give you case history in class about a couple of these that I've dealt with, and very frightening. If you're not getting enough air, you become very anxious. And it can be that a person develops a bleb. This is actually the collapsed lung. Develops a bleb like a blister, and it ruptures, and every time a person inhales, air gets out of the lung and pushes it to like a balloon collapsing with no air. That's spontaneous. Traumatic is where the lung has been pierced. We'll talk about that, case histories on that. And then tension pneumothorax is the emergent lung trauma, where there's been a piercing of the lung. There's air entering through that pierce, and because of this hole, as air comes to the lung, it escapes from the lung, and the pressure is to do this down, and it's called the Pillsbury Doughboy effect, where there's in the triangle of the neck superior to the clavicle and along the intercostal spaces, they'll have just air pushing out, and this ultimately displaces the heart and can cause heart